much. It's really enjoyable to spend time with my good friend Mehmet in such a high-quality symposium. So thank you very much for making me part of this. So I'd like to share with you some of the research that my group is doing at Boston University on recent interventions for anxiety disorders. And just briefly a financial disclosure here. So the first-line treatments for anxiety disorders, as you heard also just an hour ago in the other symposium, is pharmacotherapy. And we have the SSRIs and tricyclic antidepressants and MAOIs, but also cognitive behavior therapy, or combination of cognitive behavior therapy plus pharmacotherapy, or some more novel combination strategies. When you look at the effect sizes of cognitive behavior therapy as compared to placebo interventions, and these are psychological placebo interventions as well as pill placebo interventions, we can see that CBT is clearly effective, more effective than placebo. However, there are clear differences in the various disorders. So they're particularly effective for acute stress disorder and also obsessive compulsive disorder. So the effect sizes are quite strong as compared to the placebo. The green bars here, not quite as dramatic are the effects for post-traumatic stress disorder, social anxiety disorder, generalized anxiety disorder, and panic disorder. The effect sizes are in the strong range for those disorders. For the rest, it's rather moderate. So the question is how to improve these effects. Also, when we look at the SSRIs, this is a meta-analysis conducted earlier by Bauernstein that showed similarly a response rate for the SSRIs, as you heard earlier, of 50% range for pill placebo, slightly lower. However, as you know, there's the follow-up data look quite different. So what are possible ways to improve the effects of these treatments? And I will tell you today 3 possible areas how to improve upon existing treatments. One is by augmenting existing treatments. Second is by modifying cognitive behavior therapy to make them stronger. And the third one is to predict who might improve to treatments and who will not improve to certain treatments. Let me first say something about augmentation strategies. As you heard just a few minutes ago, the combination treatments of conventional combination treatments, meaning pharmacotherapy, anxiolytic medication, and antidepressant medication combined with cognitive behavior therapy is not overly effective. We get effect size at post-treatments in a moderate range for panic disorder and generalized anxiety disorder, and for obsessive compulsive disorder and social anxiety disorder, they are small and non-significant. And these are effect sizes of pharmacotherapy plus CBT versus CBT plus pill placebo. Just to pick out a couple of studies that demonstrate this effect. This is a study that was done by Davidson comparing cognitive behavior therapy, fluoxetine, cognitive behavior therapy plus fluoxetine, CBT plus pill placebo, and pill placebo. And as you can see, the combination of CBT plus fluoxetine, the combination strategy, is not more effective than CBT plus pill placebo, and also not more effective than any of those monotherapies, CBT and fluoxetine. And the effect sizes are only in the 50 to 60% range, significantly more effective than pill placebo, but not significantly different from one another. And 60%, 55% is not terribly good, so we want to improve upon this. This is another study by Barlow showing that at post-treatment CBT, similar to imipramine for panic disorder, CBT plus imipramine only slightly better, not significantly better. CBT plus pill placebo, however, being better and pill placebo again in the 20% range. If at 6 months follow-up, the effects of CBT plus pill placebo is maintained and is better than the combination CBT plus imipramine. So this underscores what you heard earlier on this placebo response, that placebo is quite effective, especially when combined with cognitive behavior therapy. Combining active pharmacotherapy with CBT is rather disappointing. So this brings me now to a novel idea, how to augment cognitive behavior therapy. This would now require really another hour talk to go into details. But I'm going to show you now some data that suggests that you can augment, meaning improve, cognitive behavior therapy using a cognitive enhancer. The cognitive enhancer is called D-cycloserine. Right, D-cycloserine. Just heard the translator use that word. Very good. D-cycloserine, DCS. So this gets me to the receptor complex, the NMDA receptor complex of the glutamatergic system that is located in the amygdala and also in the hippocampus, that is critically involved in learning. What we do in this particular treatment is we augment the learning that happens during cognitive behavior therapy. During a regular extinction learning process, glutamate and glycine bind to their respective receptor recognition sites of this NMDA receptor complex. And once these two molecules bind to these receptor sites, calcium comes into the cell, and that leads to long-term potentiation, which is the biological substrate of learning, long-term potentiation. If you now replace the glycine with D-cycloserine, a little bit more calcium goes into the cell, not too much, but enough to strengthen the long-term potentiation that occurs during extinction learning. This is a study that was the very first study that was conducted using D-cycloserine in humans. There is a long history of using D-cycloserine in rats, demonstrating that D-cycloserine, which is, as I mentioned, this NMDA agonist, partial agonist, facilitating extinction learning. This is the first study that showed that D-cycloserine can also facilitate exposure therapy in humans. This trial used recruited individuals with height phobias and exposed them in a virtual environment using 2 treatment sessions, showing that D-cycloserine leads to a significant reduction in greater reduction during the exposure trials than individuals who received pill placebo in addition to the exposure therapy. And these were the two exposure trials that were used. Interestingly, at follow-up, individuals who received D-cycloserine remained improved. In fact, the difference became even stronger, a little detail that I will bring up later again, because suggesting that D-cycloserine acts on memory consolidation and improves memory consolidation. This is can also be shown in a psychophysiological variable, and most importantly, people who receive D-cycloserine in addition to the exposure therapy expose themselves more often to real situations than those in the pill placebo. So this very early study was very promising, and we followed that up in the second study that was done in humans. We did with individuals with social anxiety disorder. Similar to the earlier study by Ressler and colleagues, we recruited individuals with social anxiety disorder and assigned them to one of 2 groups. They either received a brief exposure treatment of only 5 sessions to social situations, and they were conducted in group format. Half of them received a small dose of D-cycloserine an hour before the exposure. The other group received the same looking pill, only that consists of a placebo. As you can see already at post-test, individuals who received dicyclocern improved to a greater degree than those who received pill placebo. If at 1 month follow-up, these effects became stronger, again pointing to the effects on memory consolidation, and these effects again were maintained and actually strengthened further. The same effects were found in a study in Australia by Adam Guastella and colleagues. They replicated the same trial that we conducted, only using a much larger sample. Their objective was to show that this cannot be, that we must be wrong because it's too good to be true, and they actually replicated the trial using the same design, same treatment protocol, larger sample, and showed, however, the same effects. Individuals who received dicyclocern improved significantly more than those who received pill placebo in conjunction with exposure therapy. We also conducted a study with panic disorder patients, again using a rather short, only 5-session exposure treatment, and the idea was to leave sufficient room for improvement, and then we assigned them again randomly to receive either dicyclocern or pill placebo 1 hour before each of the 5 exposure sessions. And what you see again was already an effect at mid-treatment and post-treatment, and the effect was maintained at 1 month follow-up, showing that individuals who received dicyclocern in conjunction with exposure therapy had greater improvement than those who received pill placebo. Also looking at remission rate, these effects were also quite clear at post-treatment dicyclocern. Remission was close to 60%, and at 1 month follow-up even higher, again showing that dicyclocern seems to facilitate memory consolidation. So this is a review, a meta-analysis of all human clinical studies that were conducted using dicyclocern so far. We recently completed a very large trial, and we will break the blind in December. With all of these trials have only relatively small, consists of relatively small sample sizes. Ours is a very large trial of 192 to examine whether this holds up in very large samples. But just to point out a few patterns that are interesting to note. The Wrestler trial, which I omitted to tell you, also compared 50 milligrams versus 500 milligrams of dicyclocern. It did not find a difference. By the way, dicyclocern happens to be an antibiotic that is used to treat tuberculosis. This property has nothing to do with the extinction facilitation effect, as far as I know. However, when you give that as an antibiotic, you administer about 1,000 milligrams to get the antibiotic effect over long periods of time. And when you administer such high dose, it has some very unpleasant side effects. We only administered 50 milligrams, not 1,000, but 50 milligrams an hour before the exposure. This has no noticeable effects aside from facilitating extinction. People cannot tell whether or not they have the placebo or the dicyclocern. 50% correct guesses. So we asked them, obviously, did you get dicyclocern? Did you get pill placebo? They were only 50% correct, which is chance. Interestingly, there's no effect between 50 and 500 milligrams. Therefore, the smaller dose is just fine. The original study assigned it 3 hours prior to the extinction effect and the exposure therapy, and showed the effect, and only 2 sessions were used. Then I told you about our trial and about Guastella's trial. We administered 50 milligrams an hour before, and we only had 4 exposure sessions. Now, the panic disorder trial I reported to you as well. And all of these effects, all of these trials so far have been positive. So there's so far a 0 file drawer issue. all of the trials that have been conducted showed positive effects with only one single study, which is the study by Storch. Kushner and Wilhelm also showed the positive effect. What's interesting with the Storch trial is that a much larger dose was used than in the other trials. They administered it 4 hours prior to the exposure therapy, and they administered, most importantly, prior to every session, which is inadvisable, quite simply because D-cycloserine has the property that it acts as an agonist when given acutely, and it acts as an antagonist on the NMDA receptor complex when given chronically, meaning repeatedly for a long period of time. So these effects were actually predictable. Let me move on to a second strategy that we've been examining, which has to do with modifying existing CBT protocols. This is a model, a very general psychopathology model that we developed to exemplify one important point. In CBT, we believe that among many other things, we target affect. We target negative affect primarily. And depending on a person's affective style, particular triggers, situational or bodily triggers, and given a particular diathesis, a genetic makeup, will lead to either the experience of negative affect or positive affect. And we believe that negative affect has been so far our central target in treatment. And we are trying hard to relieve them from this negative affect using cognitive behavioral strategies. Patients with negative affect show a general dysregulation of this negative affect. They use avoidance strategies. They do something to get relief from their suffering, leading then to anxiety disorder. What CBT so far has focused when we talk about dysregulation is primarily on cognitive appraisal. We're asking people to re-examine their belief systems, their schemas that they have, and to practice different ways of interpreting their environment. And all this is good and fine, but it limited us up to a certain point in expanding the CBT framework. We haven't really examined much the issue of positive affectivity. And I think there's a lot more to do. And I'm going to demonstrate today a few highlights of our research protocols that point to the importance of targeting positive affect in addition to reducing negative affect. Mindfulness and acceptance-based strategies are quite beneficial emotion regulation strategies. What is mindfulness? Mindfulness is generally defined as a non-elaborative, non-judgmental, present-centered awareness in which each thought, feeling, sensation that arises is acknowledged, accepted as it is. Sort of living in the here and now, being fully aware of the present moment. And if you think about depression or generalized anxiety disorder, other disorders, they are often occupied with what's happening in the future or what's happening in the past. In the case of depression, people often ruminate about things that they should have done, could have done, didn't do. People with generalized anxiety disorder worry about the future. They worry about what's next. They worry about losing their house, finance, etc. So people are preoccupied with the past or the present or the future, forgetting that they're actually living in the here and now and not being able to enjoy the moment. This very issue of enjoying the moment in the here and now can potentially raise positive affect in addition to also targeting negative affect. But most importantly, it raises positive affect. Now we'll show you also a number of other methods how we can raise positive affect. What Dr. Kirsch also mentioned earlier, exercising is a very effective way of also raising positive affect. We don't routinely integrate it in treatment, but I think we should. Let me now go back to mindfulness-based interventions. There's a critical difference how mindfulness-based strategies work as opposed to what I would call traditional CBT. And I'm building on traditional CBT, by the way. I'm not introducing anything new. I'm adding on to traditional CBT. I'm trying to improve it, further enhance it. In traditional CBT, we primarily have focused on changing content of thoughts. And in more mindfulness-based approaches, we try to focus on the awareness and the relationship to thoughts. And this can be quite helpful with ruminative worries, obsessive worrying, obsessive thinking. Kind of being able to detach yourself from your thoughts is a strategy that would be targeted in mindfulness-based strategies. So thoughts are not facts, but I'm not, and I'm not my own thoughts. These are typical realizations people would obtain practicing mindfulness-based strategies. We conducted I was a harsh critic of these kind of mindfulness-based strategies. I didn't think they add a lot new, and my point was actually to do a meta-analysis showing that there's not much there. And so that's what we did. We conducted a very large-based meta-analytic study examining mindfulness-based therapy for anxiety and depression that don't specifically include CBT strategies, but are primarily mindfulness-based stress reductions, mindfulness-based interventions that are not closely tied to CBT. And we examined to what extent they improve anxiety and depressive symptoms. There's a lot to show, but I just wanted to point out the main results. So these are the changes in anxiety symptoms as a result of these mindfulness-based strategies among patients with anxiety disorders, depression, but also other things such as cancer or medical problems. And again, they used mindfulness-based strategies to simply have to experience stress reduction, and some of these authors administered anxiety measures where we were interested in to what extent it reduces anxiety and depression. What you see is overall, the overall effect size of reducing anxiety symptoms of all these studies was 0.63, which is in a moderate range, which is quite good. For only looking at anxiety disorders, we get actually effect size of 0.93, and also similarly for depression, only looking at depression, we get effect sizes in the 0.9 range, which is very good. It has, I should state, however, these are uncontrolled effect sizes, so they're not controlled for the placebo effect, which adds into this effect size. Yet, it's highly promising to have such a strong effect size using mindfulness-based strategies in order to reduce anxiety, depression. Here's another idea that we recently introduced, and mindfulness-based interventions are primarily sensorially focused so far. So basically, people sit, focus on their breathing, focus on the here and now, letting thoughts come and go while experiencing the present moment. Now, you can further enhance this by using additional meditative practices. In particular, we thought what has been called loving kindness and compassion meditation to be particularly promising to further enhance positive affect. In loving kindness meditation, it sounds odd, but it really isn't. It's a meditative practice in which you experience the meditative state, but then now, in addition to that, you focus positive feelings toward other people, toward not only the feeling that you might have toward your child or toward your loved one, you might direct toward strangers or even toward people you don't like. Doing so, you have this competing influence of positive affect acting on your emotional problems in addition to the negative affectivity. And as I showed you in my earlier slide, positive affect and negative affect coexist, but positive affect in a way can neutralize negative affect. Okay. Let's move on to the last part of my talk, just a few more minutes, which has to do with prediction of CBT. And I'm going to jump right into the study here. We were interested in whether we can predict whether somebody will respond to cognitive behavior therapy or not. And this could possibly be used as a diagnostic tool. Perhaps in the future, even we could use an MRI scan even to maybe assign a person to a particular treatment modality. Perhaps it would tell us whether somebody might respond better to an SSRI. Somebody might respond better to a CBT intervention. Somebody might respond even to a placebo intervention. fMRI so far has only been used to really show some nice pictures while people do something in the magnet, but had very little clinical applications. So this was now the goal. As part of a larger trial, I've been collaborating with John Gabrielli at the Massachusetts Institute of Technology, who knows this stuff quite well, and we've been collecting a very large group, a very large number of patients before and after treatment. What's most important here is to examine the predictors of treatment outcome. So we were primarily interested in, can we predict whether somebody will respond to cognitive behavior therapy based on MRI, and based on functional MRI, structural scans, and functional connectivity data and other things. So in this, in our fMRI paradigm, we had people, and so far we had collected about 60 patients who undergo the scanning pre to post, and also follow-up we have as well. So I'm going to demonstrate, have a slice of this data for most of them, but not all of them yet. So in this particular fMRI paradigm, people viewed like some emotional scenes. Okay, emotional scenes, emotional faces, neutral scenes, and then they were simply asked to indicate whether they've seen a currently face is identical or not to an immediately preceding one. So fairly simple paradigm. What we've shown first, so now the question is what correlates with treatment outcome, and some areas lit up were highly correlated with treatment outcome, and these were areas in the occipital, frontal, temporal, and temporal region. So these areas were correlated with pre to post changes. Let me illustrate that to you. So these were changes from in a measure called the Leibowitz Social Anxiety Scale. Angry versus neutral faces, the greater the activation was, the greater the likelihood of treatment outcome we had. Similarly, just for those of you who don't know what areas, ventral temporal regions and frontal parietal regions, are primarily interested in visual processing, and for frontal parietal, primarily interested in involved in emotion regulation strategies. We also shown that the same regions were predictive of the structural data, so the thickness of the white matter, also predicted treatment outcome in the same regions. Finally, we showed that functional connectivity data, that means the more closely connected the amygdala is to prefrontal regions, the more closely the connection, the better the treatment outcome. And these data were quite strong, quite convincing. Let me conclude. CBT and pharmacotherapy for anxiety disorders are effective, but there's clearly room for improvement, and I believe that you can improve things in numerous ways. Most importantly, I've shown that you can augment CBT with cognitive enhancers such as D-cycloserine. You can modify CBT by including these are actually not novel emotion regulation strategies. These are rather ancient, but we can enhance the CBT by focusing on positive affectivity and enhancing emotion regulation skills. And finally, we can predict CBT using MRI and fMRI. And that is the end of my talk. Thank you very much for your attention.